Marc Koosemansmarc. He's going to talk about evaluation of topical repellents as additional vector control measures to control residual transmission in malaria in pre-elimination areas. Thanks, Marc.
Thank you, Andrew. So, I will speak about the repellents as additional methods to control residual transmission. Residual transmission means a transmission that is not targeted by the core intervention on vector control, which is insecticide-treated nets and RIS. And this in a malaria elimination setting that is here a province in Cambodia. Cambodia got a high malaria transmission in the past, but that malaria has been reduced a lot. So, what is the situation today? We have the mosquitoes that bite, and Anopheline mosquitoes, vectors, bite mainly between 10 p.m. and 5 or 6 p.m. a.m. in the morning. So, this is very, very well covered by ITN and or residual spray. However, there is a gap where there is no protection early in the evening when the people are sitting outside, and early in the morning where there is also no protection. However, most of the transmission is addressed by this, but this still can maintain a very low level of transmission in this area. As you can see here on the graph, this is a graph of malaria transmission in the central part of Vietnam, where you can see that 60% of the vectors are biting before sleeping time, and we have all the infective bites occur, but there are no infective bites that occur during the night, but only here in the morning and in the evening. So, to address this residual transmission, we thought that in addition to ITN, it will be a very good way to evaluate the residual transmission by adding topical repellents. And of course, for evaluating topical repellents with the purpose, not in this case of personal protection, but in the case of community protection, and community protection means something different. It means that the people that are not using the tool will have the benefit of the coverage use of this tool. So that's very important. If the coverage is not high enough, it will not have impact on the vector population, meaning that the vectorial capacity will not decrease, but you still may have a personal protection. So we did therefore some epidemiological study, entomological study, and very, very important in this study was also the social sciences. So first of all, we use as repellent, we use icaridine, which was provided by SC Johnson free, so that was a great support to have this product. Why did we choose icaridine or picaridine? Because it has the acceptance is higher than DEET. However, we tried to evaluate the efficacy of this picaridine, and we can see here on different species that about 95% of the bites, or more than 95% of the bites, could be avoided by using these repellents, and this during 5 hours. So even after 4 hours, the repellent is still very, very performing and protect. With one exception, where you have a lower efficacy for Anopheles barbirostris, but still very acceptable. As you will see, also we use two formulations of picaridine, and this is comparing picaridine 10%, 20% to 20% DEET. DEET is the green part. And we use 20% picaridine for adults in the spray formulation, and 10% picaridine for children below 10 years in a lotion formulation. So it was a randomized control trial that was implemented in the province of Ratanakiri in Cambodia, so at the border of Vietnam. And you can see here the villages that we tried to follow up during 2 years. So in yellow you have the control village, and in blue you have the intervention village. So this is the design. It's a randomized control trial with about 170 villages we selected. That were the villages providing the highest incidence based on passive case detection. And during a peer trial we got 34% malaria prevalence in the whole region. So this is based on PCR detection. If you can see that in the past, in 2000, we got prevalences in this region about 70% of malaria infection in the communities, but this 70% was detected by microscopy. So this is 6% by PCR, showing that the decrease has been very important. So you can see that after that we divided the villages in 2 parts, and at the baseline we got very low, we got a similar prevalence in the control village, where they received only bed nets, new insecticide-treated nets, and in the intervention village where they received in addition the repellent. And this study was done during 2 years, and after 2 years we tried to evaluate the impact. So this is based on a population of about 40,000 inhabitants, 20,000 for the control and 20,000 for the intervention. So this implies a very good system of repellent distribution and distribution of long-lasting nets. So all the people receive a long-lasting net, about 1 net per person, and the distribution of repellents was done with leaflet, a lot of education campaign, and mainly because in the first year the distribution was not optimal, we improved the distribution system by increasing the number of people so that they can also reach the very remote areas. So this gives you an idea of the contact with the repellent distributors. So we have about 100%, we estimate about 100% contact if the people will be in contact, if the distributors will be in contact with the households every 2 weeks during about 9 months. And you can see that during the first year the number of contacts was not so high, but still we achieved. Everybody knows about that, but this was considerably improved during the second year. Regarding the consumption, the average consumption of repellent every 2 weeks, so we expect that if they use it only once a day, we expect this a little bit less than 100 milliliter every 2 weeks, and we can see that also in the second year this was largely improved. However, very few people were using the repellent 2 times a week, 2 times a day. So our indicators is the malaria prevalence detected by PCR with a mobile lab that was done by the Pasteur Institute under the lead of Didier Ménard. The seroprevalence we detected 22 antigens, and the passive case detection by the different malaria village workers. So the results, you can see here the results of the PCR prevalence for Plasmodium, for Falciparum, and for Vivax, and you can see that there is no difference between the control and the intervention arms for the 3, for Plasmodium, for Falciparum, and for Vivax. So this was a little bit disappointing, and you can see here the same outcome we can see for serology. There was no difference for serology between the 2 arms, and also for the passive case detection that was based on the malaria village workers. So regarding the social sciences, we look also to the accessibility, and the accessibility was largely improved during the second year. but after that you have the acceptability, and the acceptability was very, very high for mosquito repellents as protection against insects, but also alternative use. There were some negative points, was the toxicity, the smell, but the smell in two ways. Sometimes if the smell is absent despite the product is still active, people believe that it is not effective anymore against the mosquito bites. But we note also a lot of alternative use of repellents. They've sprayed on the bed nets, on the houses, on the insects. So that explains the use and the non-use. So finally, we could see that men were using more repellents than women, that the use was more important in adults, and people prefer to use it when they go to the forest than using the repellent when they are in the village. So we got a very high acceptance rate and a high reported rate. Up to 76% people report that they use this evening the repellent. I saw that there was a presentation on reported use of ITN. So what the people are reporting is not always the case. They want to please to you, and this is not always the reality. In fact, when the social team was observing the use, well, you can see that the use during the evening was only up to 15%, and this will be presented in a poster by Charlotte Grisels. So in conclusion, the repellent is picaridin, in this case of C. Johnson, is very effective against vector bites and could assure personal protection against malaria, as it was demonstrated in Bolivia with Hill. We show also that the access to repellent was considerably improved during the second year of the trial, even in very remote areas on the forest plots. There was a high acceptability of the repellents in the community. However, the low daily and consistent use of repellent was responsible for a low effective coverage. And so with a low effective use of repellent, this explains probably the absence of additional community protection against malaria in the region. So again, it's community protection, so that means that it has no impact on the malaria prevalence as such, but still can be used as individual protection. So I would like to acknowledge, of course, the National Center for Malaria Control in Cambodia. They did a wonderful job in implementing this. The Institut Pasteur du Cambodge for all the molecular work, and also my colleagues from the Institute of Tropical Medicine. Thank you very much.
Any questions? One over here. Can you come to the microphone? Thanks.
So we're coming with the same question. I'm Tom from Madagascar. Did you observe a change in entomological indicators? Because you measured it, right?
So we have some surveys in the different clusters for entomological indicators, but so far this has not been completely analyzed. But the first results show that there is no impact on the vector population.
How much? Sorry. I'm Janta from Cambodia. A bit sensitive question to your study. I heard that some of volunteers were suicided on that during the study. I think maybe 4 or 5 volunteers. So can you explain what is the factor that the volunteer try to suicide on that, killed by themselves?
I did. Yes.
Could you one more time, a little bit more slowly, to say your question again, please?
Yeah, I heard in your study that several volunteers were suicided during the study. Killed by themselves.
Oh, they had suicide.
Oh, yes, yes. Well, yeah, yes. Well, I can reply on this. So we got a very few number of cases of side events that are well documented very, very early. We got also some tentative of suicide in this, because people think that this is a very toxic, and we know that suicide by insecticide is very, very common in poor settings. So people thought that using this repellent could be a good way to suicide, but it's not effective at all. So now people know that this is not the best way, and but there were because we got also a pregnant woman, and there were no, of course she was hospitalized, but after that she recovered very, very well with a very, very nice baby.
Do they take it internally? They drink it?
Yes, they drink it.
Okay, one more. We move on.
When you introduce a new, as I understand, totally new product in an area like repellent, which they don't have customs to use, did you do anything to adapt the product, like odor, like anything that would simulate what they might accept instead of just coming with picaridin?
Yes. So we did a lot of campaigns, and we spent a lot of money for improving the communication and acceptability of the repellent. And as it was shown, the acceptability was very, very high. So we make also some movie, funny, not boring, very funny message. That's something that we should learn in public health to make it pleasant for the people. They recognize the environment, so the acceptability was not an issue. But as for everything, if you are going into an environment, you use repellent, you will also not be so rational as we may think in public health.
Thank you very much.
Thank you.
Okay, very quick.
Yeah.
You stated that there was low consistent use. So what do you attribute that to? As I understand, you did communication campaigns. So I was just wondering what the reason was.
Well, there are several reasons. Some people don't like the smell. But again, this is a paradox, because if the smell is not present, they think it's not effective anymore. And also for children, when the parents are coming back from the field, they don't have the time to take care of the children, and so it's normally the parents that are applying the repellents to the children. So they don't have the time to do it, and for many other reasons, you should just see how will I do in the same conditions. And you start yourself to use the repellent once you have nuisance. If you go to the forest, or if you go to a plot and then you are bitten by insects or leeches, so that's when that's where we are using repellents. So it's different from ITNs, where the ITN, the insecticide nets, are covered on the bed, so you just use it. But here you have to take the bottle to put it on your arms every day. So will you do that? Maybe not, but at least, well, we could see that this is maybe not a product to be recommended in public health program, but it is a product that can be recommended, that should be recommended for specific working groups, like people working in rubber plantations.
Okay, thanks, Mark.
Thank you.